Good morning, good afternoon. Hello to all of you, and thanks for making time to join us today for our webinar on elder justice. My name is Amy Herrera. I'm a special agent at the FBI's Washington, D.C. field office, as you can see over my head today. And before we get started with the content today, I have just a handful of quick administrative announcements for everyone. First off, yes, we are recording this session as we recorded all the others. So I will share with you the link in the chat where you can find the recording, which probably will be available towards the latter part of tomorrow. So look for that to come. We are giving you a handout today that you can download at your leisure, take with you. It'll be posted on the website tomorrow as well. The handout consists of a PDF of the slides that our second presenter is using today. So it has a ton of resources on it. You're welcome to take those with you and share them as far and as broadly as you would like. If you are a member of the media attending today, fantastic, glad to have you here. Please reach out directly through the chat or through the question box, and we'll connect you to the appropriate public affairs person in our shop who can help you prepare your materials as needed. If you are joining today for continuing education credit, we do not issue those credits directly. However, tomorrow you will get an email and a certificate that confirms your attendance today. So you can take that certificate, submit it to whatever organization typically issues your CPEs, and get your credits that way. You will also see today when you exit the webinar, and again tomorrow in that email that confirms your attendance, a link to a survey to ask 2 questions about what you think about today's session. We appreciate all your comments. We read every comment and we adjust how we do what we do based on what you tell us is working or is not working. So please do share your thoughts on that survey. We greatly appreciate it. If you have questions, we welcome your questions. This is meant to be an interactive session. So as a question occurs to you, please pop it in the question box. We will get to as many questions as we can, with a caveat that we're going to save the questions until towards the end. We have a lot of content to get through today. We want our presenters to have sufficient time to walk through all the materials that they have to support for you. Today is one in a series of what we have called the Elder Justice Project. So last month in May, we focused on financial frauds that affect older adults. We had a series of 3 webinars on those topics. All of those were recorded. All of those are available through that you can watch anytime you'd like. This month in June, we're really focusing on healthcare topics. So healthcare fraud and matters of abuse and neglect, particularly those that impact older adults. And in fact, today is World Elder Abuse Awareness Day, which happens every year on June 15th. So you'll see most of our speakers wearing purple today, which is the color of World Elder Abuse Awareness Day. That means it's so appropriate that our case study today really focuses on abuse and neglect in a nursing home setting. So I'm going to ask my co-presenters to turn on their cameras while I just finish up my admin announcements. Excuse the phlegm in the throat. This series is joint between the Washington, D.C. field office of the FBI and InfraGardNCR, the National Capital Region chapter of InfraGard. So thank you to InfraGardNCR for the platform that we're using today. We're doing this project with a ton of partners, nonprofit partners and government partners. So you'll hear from government partners today and also from the National Center on Elder Abuse. So Julie Shane, who's there, and is probably going to wave a hi. She's Deputy Director for the National Center on Elder Abuse. She's going to speak later on today. So first, I'd like to introduce our 2 speakers up for the case study. So first up, Steve Grist, who prosecuted Medicaid fraud and patient abuse and neglect for 15 years. So tons of experience there. And most of the time, he partnered with Marla Vanderbunt, who's a special agent in the FBI's St. Louis field office. So the 2 of them are going to work through a case that they handled to illustrate some of the issues that come up with abuse and neglect. Whew, that's in the admin. Hot dog! I turn the virtual microphone over to Steve and Marla. Take it away.
Hello, as was mentioned, my name is Steve Grist. I'm here with Agent Vanderbunt. Marla and I work together very closely, like was said, for about over 10 years. We prosecuted several cases in federal court and state court, but almost all of those cases related to Medicaid fraud. Specifically, they were about billing for services not rendered. So what we'd like to talk to you today about is a specific case that she and I investigated and prosecuted related to patient abuse and neglect. It was in a nursing home setting. So if the second slide could come up, the case focused on two patients, Jack and Betty. Jack was a 70-year-old dementia patient who had been found by a court to be incompetent. He had suffered a stroke. He was partially paralyzed. He was 100% bedridden, 100% dependent on care. Therefore, he was extremely vulnerable. He could not articulate care at all, or the quality of his care or lack thereof. So he was, like I said, a very vulnerable patient. And Betty was similarly situated. She was in her 70s, had dementia, but she also had an additional complication, which was diabetes. So she was especially vulnerable because in patients who are 100% bedridden, diabetes is especially dangerous because of the lack of blood flow to your extremities. If you get a wound in your feet or your hands and it's not properly cared for, it can turn into sepsis and the patient can quickly die. And indeed, because of a lack of care, that's exactly what happened to Betty. She developed a wound in her foot that was not cared for, and she ended up dying from sepsis, which is an infection of the blood. Next slide, please. The investigation was run by Marla Vanderbunt, the agent in charge, and so I'm going to let her talk about this particular slide of exactly how the investigation was run.
Yeah, so it's kind of how we start. We mentioned Jack and Betty, but that's just a small subset of all the victims in the case. But when it comes to putting a case together to find justice for the victims, we often have to narrow it down to individuals as counts in order to charge for it. So that's, I don't want to say this case is just about Jack and Betty. It was an overall problem, but in order to prove these allegations, we narrowed down to Jack and Betty. And when we did that, part of that process was finding loved ones or caregivers or spouses or, sons or daughters who can help advocate for that caregiver, because you rely on them quite a bit. It becomes a relationship in sense of you have to communicate back and forth very regularly, because in these cases, you're often throughout the process, you become aware of neglect or abuse in the moment. And then you don't want to hide that from the actual caregivers because something is happening to their loved one. So that is, a crucial part of working through this, having that open dialogue. And once you establish that, now how do we prove it? And proving it is you need evidence, obviously. And we decided to install video cameras within the nursing home patient rooms with the consent of the caregiver. And as we're running the 24/7 surveillance in the rooms, we're gathering the medical records for the same dates of service and the same times. And this is, where, in life, right, a lot of life moments takes a village to be successful. In this case, it did that. And we worked very closely with the Medicaid Fraud Control Unit and their registered nurses and their investigative staff to help do the side-by-side comparison with what we see on the video camera and then what we see in the medical records. And that's where you start seeing the falsifications. And that becomes a very crucial part of proving fraud, right? That's ultimately the crime in the case. A lot of times is these facilities or the home health agencies or whatnot are billing for services that are not provided. And so we gather a lot of medical records through subpoenas and whatnot. And a lot of times is what happens. Medical records say one story, but you have to do a lot of interviews of witnesses, which includes other patients, other caregivers that had their loved ones in the facility, and also employees and former employees, because oftentimes there's two stories. Medical records tell a story, but it could be, well, that actually means this or that. So it's kind of putting all these little nuggets together to get a full picture of the scope of what's going on in the facility. And we rely on experts, right? I'm not a doctor. I'm an agent that works healthcare fraud. So we want to rely on, subject matter experts to tell us exactly what these records are showing. There's a lot of acronyms used and just spelling that down in layman's term for everyone to understand. And part of it, watching the video, and as if you have a loved one or you are, in this process, we started realizing the patients we had were mostly nonverbal. But when we would see certain staff come into the room, the patient would react differently to different staff. So we started recognizing if, staff A walked in the room, the patient would get very agitated, start moving around in the bed and being agitated. And then other staff, they would be very calm when that staff walked into the room. So those are signs. And, as the case progressed, we started noticing the patients or the staff that walked in when the patient got agitated were most likely, in most cases, the ones that were doing the abuse and neglect in the patients. So it's just being aware of those nonverbal cues as well. And staffing analysis, right? Did they have the staff to actually provide the services? And, I often say in investigations, sometimes law enforcement, we're often thinking, how do we prove these allegations? How do we prove that a crime was committed or was not committed? And so sometimes in that process, we can come across a little bit callous or, insensitive to the actual matter at hand. And it's not intentional, but, I always encourage, the caregivers or the loved ones or, whoever to have that open dialogue of communication. Because it's not, in that process, we're just trying to figure out how will these allegations and what is needed to prove these allegations. And some of the questions, in that process, you become very direct, and it's not, against anything. It's just in a way to help prove the case. Steve, you have anything to add?
Yes, regarding performing staffing analysis, in this case, when we looked at payroll records versus the medical records, it was very interesting. The medical records would show that a particular staff member, nurse's aide, a nurse, even doctor worked on a particular day, and you would look at their payroll records and they didn't work that day. So that's a big cue, and that's a great example of what we looked at to prove that certain types of care were not being performed. The other thing I would add is both Betty and Jack were selected as patients because they were bedridden. And one of the common defenses in these cases is that the care was provided outside the room. So if the patient was mobile at all and could leave the room of their own volition, then it could be argued that while they were outside the room, they got the care. And so when you're running a video like we were in this case, it was very important that the patient not be mobile. And so Jack and Betty were picked for that very reason. The other reason they were picked is because their family members, we were very confident that they wouldn't spill the beans on the investigation. I mean, the worst thing that can happen is if a family member in a moment of frustration or anger reveals that the nursing home is under investigation. And that would have destroyed this investigation because it ran so long. It ran, like Marla said, for 34 days. So next slide, please. As the investigation concluded and we looked at all the medical evidence, the overall picture became very clear at this particular nursing home, there was a culture of falsification. The medical records did not agree at all with what the video showed or what the family members said. So that culture of falsification was rather pervasive. We actually saw video of employees, nurses, aides sitting down and filling out a large number of medical records. And that's a big problem because under the standards of care, a medical record is supposed to be prepared at the time of the treatment. It's not supposed to be, it's not allowed to be completed later. That's a part of the standard of care. Furthermore, there were, as you might imagine, there were many medication errors, that medications that they claimed they were giving, the video showed they were not giving. Substandard wound care and prevention was a huge problem. Obviously, with Betty, it caused her death. The same thing with incontinence care. One of the things we learned was that the patients were only getting one diaper change per shift, and that always happened at the end of the shift. And we wondered why at the end of the shift, and we figured it out is because they didn't want the next shift complaining about having to change a diaper first thing on their shifts. So they just didn't want the next shift to be angry with them. So each patient was getting one diaper change per shift, which is woefully inadequate, especially in the case of Jack and Betty, because they were bedbound. They were immobile. So incontinence care is really important because it's dangerous not to have regular diaper changes, because if it turns into a bed sore, which it can easily do, it can turn into sepsis and they can die. Diabetic care was substandard, again, in the case of Betty. There was the sanitation infection control was substandard. When they were alerted to problems, as they often were, the facility didn't take any corrective action. And this was in large part because the management we couldn't tell if they were indifferent or if they were overwhelmed by the culture there, that it was very difficult to get quality care providers. And I mean, they don't make much money, and the turnover rate was very high at this particular facility. And if you total all of this up, 1 through 9, what you end up with is the last point, which was there was substantial harm to the residents, as you might imagine. It wasn't just Jack and Betty. Betty, as we said, ended up dying. Jack suffered through not only neglect, but there were situations that were revealed on the video that were abusive. One of the nurses thought it was funny to torment Jack. One of the nurses' aides also thought it was funny to torment Jack. And if we didn't have the camera in the room, we wouldn't have known that. So in this particular case, there was a substantial and pervasive harm to several residents. Next slide, please. So what we learned, the primary thing we learned was that every patient needs an advocate, and ideally more than one advocate. As we said, in this case, Jack had a wonderful advocate. His wife was there probably 4 or 5 days a week. And Betty also had wonderful advocates. Her daughters were there very regularly. They were very involved in the facility. They even started a Bible study. So, but as an advocate, it's really important to regularly visit a patient, get eyes on what's going on. Ideally, multiple sets of eyes, because you know, if they know you're there, they're going to be more likely. If the staff knows you're there, they're going to be more likely to care for that patient. And so to that end, it's important to get to know the staff. Some of them will be your advocate. They'll tell you what's going on if you befriend some of the staff. Become familiar, this is really important, with the standards of care. Depending upon your loved one or the patient's circumstances or medical needs, there's a standard of care. In other words, there's a standard of care for a diabetic patient. There's a standard of care for a bedridden patient. There's a standard of care for an Alzheimer's patient. You have to be familiar with those standards of care so you can know what your patient's needs are and also how they're supposed to be treated, what the medical treatments are supposed to be. And then obviously you make sure that those needs or those standards of care are applied to the patient based on their medical condition. The other thing that's important is to ask to look at the medical records. In order to do this, if the patient is aware or competent, they can give you permission to look at the medical records. If they're not competent, you need to get a court to declare them incompetent and appoint you or someone else as a guardian that can give you permission to look at the medical records. And these medical records are known as MARs and TARs. A MAR is a medication administration record. A TAR is a treatment administration record. Everything that happens to a patient should be recorded on these documents. In the nursing community, the standard is if it's not recorded, it didn't happen. So don't be afraid to ask for these documents because every diaper change should be on there. Every turning and positioning should be on there. Every time they get medication, it should be on one of those documents. Every time they're fed, it should be on that document. And if they're not there, it didn't happen. But if they show up on the document and you were there and you saw that it didn't happen, that's a problem. So the other thing to look at is incident reports. An incident report is something like if a patient falls or if a patient has an injury or if a patient is hurt or during transfer, an incident report must be generated. Ask for incident reports if you see a bruise, if you see a swelling, if you see something out of the ordinary where it looks like the patient was hurt. Ask to see an incident report. If they don't exist, again, that's a red flag. It could be that something is going on, and you need to get to the bottom of it. Also, please check for wounds, especially on the buttocks and feet. If a patient is bedridden, bed sores can easily start, and once they get started, they're hard to get under control. And where they typically start is on the patient's backside and on their feet. Don't be afraid to take photos of things that you see. When you see injuries or wounds, if you have to go to the administration of the nursing home or ultimately to law enforcement, a picture or photograph goes a long way in telling your story that just words alone can't convey. When you're looking at these medical records, verify that wound prevention and wound care is properly being given. Verify your medications and diaper changes. Diaper changes, as I've said earlier, are extremely important. And sadly, or understandably, I guess, the staff doesn't really want to do them. It's unpleasant. So, but if they're not being done, it can easily turn into an ulcer, and the patient can get sepsis and even die. Turning and positioning, very important to a bedridden patient. Again, that should be recorded on the medical documents. If while you're there, you should ensure that those things are happening. Nutrition, sanitation, very important, obviously. But in one of the things that was, or the facts that were very helpful to our investigation was that Jack was declared incompetent and his wife was assigned as a guardian. And the reason that's important is because one of the first lines of defense is for a nursing home or even an at-home care situation is the patient refused the care. Well, if a patient is declared incompetent, they can't refuse care. So it eliminates a line of defense for the care providers. So if you can, go to a court. You may need the help of a local attorney, but go to a court and ask the patient to be declared incompetent and have you appointed as a guardian or a family member appointed as a guardian. And again, photograph your observations and keep a journal of all of this. Keep a journal on good days, keep a journal on bad days. so that you can compare the two sets of notes. This is how my loved one was doing when the treatment was being provided this way. This is how my loved one was doing when the treatment was provided on this day in a different way. And attach photographs to those journal notes, so that when you go to the administration at the nursing home or you go to law enforcement, you have a story to tell. Now, ideally, you won't have to go to law enforcement. You'll be in a nursing home. Your patient will be in a nursing home that will respond to diapers not being changed, or the patient not being turned in position, or inadequate nutrition. But if there is a problem, you need some evidence other than just your word, because very often they rely on the staff and they may not believe you. And finally, as an advocate, one of the things Marla and I learned is it's your job to make sure that the staff understands that this person matters very much to you. There's a certain percentage of the staff and this includes doctors, this includes nurses, that won't look at your loved one or the patient as a person, as a human being. And as an advocate, you have to make sure they understand that this person matters. And if you don't convey that, the patient is much more vulnerable. So next slide, please. So this slide's a summary of what you should do if the problems are persistent and you have to go outside of the nursing home or outside of the administration of the provider to seek help. And Marla, if you would talk about this.
Yeah, so, oftentimes, we talk about the advocate being strong, and in every case I work, I always worry, I deal more with those advocates, and there's always patients that do not have the advocates, and we rely on the paperwork, right? Because we know that, harmful things are also happening to those patients. So I also encourage you, like in a nursing home, if, you have a roommate in the room, or, down the hallway, if you notice something as well, to look after those other patients that don't have advocates that are coming in. And if you, oftentimes if you feel something is off, that it very well could be. So we, even if you have a caregiver that you really like, and you feel like it's doing a good job, take that extra time every so often to examine your loved one, or, or yourself, right? Like if it's you, you take that time to examine that patient, and don't, obviously you don't want to offend your caregiver by doing that, but I think it is helpful, because even if you will spot those things if you feel something is off, and document what you see, which is very, very critical, because these cases are sometimes tough to prove, and documentation is very key, because in the settings, as we go through this, we interview staff, sometimes we've realized that in certain settings, it becomes a culture, right? Like, a patient or an employee was like, oh, I thought we only had to change the diaper once a shift, because everybody did it that way. Well, that's not what was supposed to happen, but they just thought it was because everyone did it that way. So just, those are kind of things that end up standing out. Like Steve said, and if you feel like it becomes to a point where you want to report your findings, or talk through with what you have with someone, the local district attorney's office, the Commonwealth Attorney's Office, the state attorney general, the Medicaid fraud control unit, your local ombudsman office. There are many different avenues. The civil attorney, specializing in patient abuse and neglect, and Department of Health and Human Services, and obviously the FBI. And I know the next presenter is going to give you some more options as well. Steve, you have anything?
No, that pretty much covers it. Hopefully we still have time for questions.
I think that we do have time for questions, but we're going to save those questions, I think, until we give Julie a chance to walk through the things that she has to share. So thank you, Marla. Thank you, Steve. Julie, if you want to pull up your slides while we transition here. This must be like the Super Bowl, right? for where you work, because it's World Elder Abuse Awareness Day and you're at the National Center on Elder Abuse. So Julie, I turn the virtual microphone over to you in your role as Deputy Director for that center to share your thoughts about resources that are available for folks.
Thank you so much, Amy. I have to say I am just in awe and appreciation of what Special Agents Marla and Steve have presented, and I'll reflect more on that as we move forward. But what an opportunity to be here on World Elder Abuse Awareness Day, and you two are definitely my heroes today as we move forward. I am, as Amy was saying, the Deputy Director of the National Center on Elder Abuse. We are a program that's funded by a grant from the Federal Administration on Community Living, the ACL, to a grant to the Keck School of Medicine of USC. So when you visit our website, this is what you would see. And what we are working with is a group of different partners from different elder justice groups also. The APS TARC that gathers the information from adult protective services around the country. Nickler, an elder justice group that we combine efforts with often. The National Ombudsman Resource Center that I'll speak more to in a few minutes, and various other groups. And the importance of this is that we're all collaborating and talking and working together. And you would contact the National Center on Elder Abuse as a resource center. Unfortunately, we're not an investigatory agency. So if you contact us and say, I don't like what's going on over at my neighbor's house, your colleague from Wisconsin, we would give you those resources that you could reach out to in Wisconsin so that you could make a report and gather more information and be of assistance. And we would highly encourage you to do that. People can call us. We have an 800 number. We have email connections, and we also have a very prominent social media profile, so you can reach us through many different ways. And we have a lot of publications. So any of the topics, and I'll be going through them in just a moment, that you might need assistance with or help with, we are here for you, because it is our mission to improve the national response to elder abuse. Right now, we have a long way to go, but that's why I'm so impressed at the presentation of the speakers before me, because it shows the work, the dedication, and the passion that's happening. Because all of us that are here today share something in common, not just an interest in the subject matter. We're all aging. Every single one of us is aging. From the minute we're born until we die, we have that in common. And aging is a good thing. It has challenges, but it has a lot of power to it also. And so when we make ageist comments that undermine others, that contributes to elder abuse. And I'll go into that a little bit more as we go forward. But we want you to realize that our population is aging. It's a powerful thing. But elder abuse in itself is also increasing exponentially as our population increases. And we know that 1 in 10 Americans age 60 and over experience a form of elder abuse every year. And actually, I just saw a study that came out this morning that puts that number at 1 in 6. And we'll go through those different types of abuse in just a moment. And as I mentioned earlier, there is a prominence of, due to good medical care and different innovations that we have, we're growing older as a society, and we're growing older healthier also as a society. Important to remember, and very powerful, that a lot of us, as we go into our later years, we have a lot of control and say, and we need to exercise that. 67% of victims are women in cases of elder abuse. And if you think of that, that really makes sense, because women do tend to still live longer than men by about 7 years, and we tend to be the caregivers for our loved ones. So often our spouses or partners will pass away before we do, and then we're left, and we can sometimes be isolated and a little more susceptible to different forms of abuse, because we are isolated and disconnected from resources and programs that are available to help us, that we'll be discussing. And then only 1 in 24 cases of elder abuse probably ever are reported, and that's probably a conservative figure. And if you think about it, it makes so much sense. If your caregiver is your abuser, you're going to be very reluctant to report them if this means the difference between you staying in your own home or going into a nursing facility. Or if you, like many of us, we see ourselves as an intelligent person, but then we become involved in a scam of some type, a lottery scam, a grandparent scam, we become embarrassed because we think we shouldn't have fallen for it. And I always tell people, oh my goodness, people are so good at what they do. That's not the factor here. We want to talk about now what's happened and how we can help a person. But you can understand why people are reluctant to report. And so we want to move the needle forward on that and have people be aware that elder abuse is wrong and that they need to report and let us know. Now, elder abuse is multi-layered and complex, and all of these different types of abuse can happen separately, but often are multi-layered. Physical abuse that was addressed today, this does not get enough attention at all. This is something that, you know, we think, oh, well, you'd see something if someone were abused or there was bruising going on. But a lot of it can be very subtle, as was described today. And in the nursing homes, without visitors and people coming in and checking regularly, we hate to think how much of this is really happening. Psychological abuse, very difficult to always put our finger on and be able to isolate in a type of feeling of someone being demeaned, and it often is layered on other types of abuse, especially the physical and into the financial. Financial elder abuse gets a lot of attention, and rightly so. It impacts so many people, but it is also something that we have a lot of resources for, and there's a lot of work going on. So I want to see some of these other areas bolstered up accordingly. Sexual abuse gets very little attention. We have probably no idea how much is really going on behind closed doors, and there needs to be a lot of work and attention paid to this particular field. And neglect is the #1 form of elder abuse. As was pointed out by our special agents today, neglect can occur within homes, within nursing facilities, and it really needs to be addressed, because as we all age, we all want to age with dignity and respect, knowing that not only our loved ones are cared for, but that we can look forward to having a long life that is full of quality and care. So I wanted to point out some of the basics. I also wanted to point out that what I'm showing you in these icons represents some of the tools that we have available to all of you to utilize. So some of you are from the public, some of you are working professionally in the field, and you may be asked to put together a presentation or provide different resources. We have those all for you. We have a program called Support and Tools for Elder Abuse Prevention, which have a lot of these different flyers and different presentations that are already made and available for you, that you can simply put your information, put your phone number, put your agency on, and utilize and take them away. You don't have to ask us for permission. So this demonstrates these products as well as gives you some of the signs of elder abuse. I thought it was amazing when Marla was talking about, you know, looking for those signals that something is happening. An older adult who seems anxious when someone walks into the room. Maybe they're not verbal, but they certainly have this look of fear in their eyes, or they withdraw more or go to comforting behaviors. Financial abuse, you walk into someone's home and the bills are stacked up unopened, or there are forged documents, or someone not being aware on their bank statements of someone else having access. So these are all other red flags. And then the physical signs of abuse, where someone is not receiving proper nutrition, they don't have the things that they need. Their walker is way across the room and they are unable to get out of their chair because somebody has put it out of their reach, that they are made to be more dependent. All the unexplained injuries, bruising, broken bones, lacerations, unsanitary living conditions, the person isn't being taken care of. And probably a very, very subtle form of abuse is over-medication, using chemical restraints to control someone. It also can be that leads to the opioid epidemic, in that drugs of an older person are being taken by a caregiver or sold. And so we want to pay attention to these types of abuse also as they happen. So, as we mentioned all of these things, do know that elder abuse is definitely preventable. What we've just seen with the FBI work is that it took a community and a village. It took the people themselves, it took their family members, it took different parts of the analysis team and the FBI to put these cases together. And that's what we're seeing. We're seeing that many groups and organizations are collaborating, sharing information, sharing resources. The FBI refers to us often for resources, and then we refer some of the more high-profile cases that we receive to the FBI. So it goes hand in hand. There are multidisciplinary teams that work specifically on these cases, and they'll have people from the banking industry, they'll have people from the district attorney's office, all working in conjunction to go through these very complex and difficult cases. So that it gives me a lot of hope that a lot of great things are happening. We work very regularly with Adult Protective Services, with the National Adult Protective Services Association, and there's links to their information so you can find out where your nearest APS office is easily. We're gathering more statistics through APS TARC. And we work very much with a group called Consumer Voice that works for the rights of people in long-term care facilities, as well as with the long-term care ombudsman. Most people do not know that there's a long-term care ombudsman available in licensed facilities there to assist them and help them and be outside of the realm of the person who might be experiencing abuse. And these people have been so courageous and helpful during COVID when people really were cut off and isolated within facilities. But if you don't know about the long-term care ombudsman, I definitely want you to reach out, look at their materials and all that they have to offer. Okay. All right. And then one other resource that I want you to be aware of today is another program that we work with the Department of Justice. And this is called the Elder Abuse Guide for Law Enforcement. The EAGLE program started out because law enforcement was not very responsive to cases of elder abuse. They have a lot on their plate. They have a lot happening. These cases are difficult. Sometimes the older person has given someone money or funds, difficult to prove, etc. But we've learned so much over the years that we put this together in a web module. And not only, so it was designed by law enforcement and for law enforcement, but you can use it. You can access it, whether you're a private individual, an APS worker, an ombudsman, someone else in the field, where this would be useful to you. So all you have to do is go on to eagle.usc.edu. That will pull it right up, and actually it's been refreshed, so it looks a little even cleaner than this. And say you wanted to know, well, I'm in Tennessee and I want to know, what laws are there to protect people about elder abuse. In the top part of this, you'll see where there are state-specific laws. You'll click on that. It will take you to a map of the United States. You'd click on Tennessee and it will pull up all the state statutes that have to do with elder abuse. So we want you to know about that and utilize it and make it handy for yourselves. We have a lot of resources on here for law enforcement, but we've condensed them into what we call our 3x5 card format. So it's a quick and easy, like questions to ask, things to look for, make that available. And we have a lot of resources also in the areas of how to photograph a bruise, how to talk to an older adult, because sometimes people don't know how to talk to older adults. They talk to the caregiver, and if the caregiver says, oh, they're just fine, they're just sleepy today, is it that they're over medicated or they haven't received their medications? You want to lay eyes on that older adult and you want to talk to them and you want to see how they're doing and what their responses are, even if they're not verbal. We also have where you can put your zip code in and it will pull up all of the older adult services in your area. Usually starts with APS in your area, and then it might go to the Office on Aging in your area, other social services programs, the state health insurance assistance programs, the SMPs, which are the senior Medicare patrols. So those are all laid out for you. It's meant to be vetted, more leaning toward government entities, because we cannot put everybody's resources here, but very, very valuable. People tell me all the time, thank you so much for having this. And we work in partnership with the Elder Care Locator for this resource. So it's just become invaluable to us and to the communities. So you can utilize these. We have an evidence collection checklist, and we also have a first responders checklist. So when an officer walks into a room and wants to just make some quick notes, we have that they can do it on their computer, iPad, or if they need to print it out, it can be in a printable format, and then they can just email it to themselves. We don't collect any data or information. It's all private to the person utilizing the form. We don't have that capacity. There's just 3 of us that work on this program, and we appreciate your insight and your input and your corrections, because you might be in a local office and say, hey, that phone number's changed and they haven't updated it. Call us, let us know. We would want to keep this as up to date and credible as possible. The elder care locator people do a great job in doing that on their end, but you know, it's a big country with thankfully a lot of good resources, and sometimes we don't have the latest and greatest, so please provide us with that information. If you'd like it on your phone, very easy, the same thing, eagle.usc.edu, and you can have it on your phone, and this is kind of what it would look like coming up in a mobile format. So just hope that that's helpful to you. And for the rest of resources, I just want you to see that we have a lot that we don't want you to have to reinvent the wheel. There's a lot out there for you. And so we have a whole compilation of training resources on elder abuse. So if you want to learn more about sexual abuse in the elderly population, there are videos and trainings that address that very specific issue, and they're very impactful. If you want to learn more about financial abuse, so you can go to that website. And then we also have new messaging about elder abuse. We want people to know that this is an elder justice issue, that there are solutions, very workable. It's not overwhelming. It's a problem that we can, as a society, work on and resolve. And so we have a lot of tools and a whole toolkit for you on that area. Then we have the Eagle kit that I mentioned to you earlier. That's there for you. Inevitably, somebody says, can I use Eagle? Yes, it's for everybody. There's no cost for it. The Department of Justice very, very generously funds this program for us, and it's there for you. And then I mentioned the Support and Tools for Elder Abuse Prevention program. That is for you if you need any little brochure, information, flyer. We put it all into bite-sized pieces for you, and you can just put your logo on it and your phone number and utilize this. And then at USC itself, we have a lot of research going on in the field of elder abuse. We're finding out, why do people make the decisions that they make? Is that something with different areas of the brain? We have papers and innovations, and a conference that goes on, a symposium that goes on every other year. So if you need more information about that, we want to make sure that you are aware that that is happening. So today is World Elder Abuse Awareness Day. It's not too late to join in. Just you being here today, to me, signifies your interest. And so we want to make sure that you know that there are lots of tools available for you for World Elder Abuse Awareness Day, and to get you ready for next year also. So you can visit our website, and we will provide you with everything you possibly can want to start a community program, or just yourself. We have a walker tracker project that people are very competitive with, where they're doing virtual walking and tracking things on their devices, and it's very good. So we have that available to you also. So there is our phone number for the National Center on Elder Abuse. I know you're getting copies in PDF of all of these resources, so you'll have them. You can visit our website, and you can email us, and we'd be happy to answer questions through that. We have, as I mentioned earlier, a very robust social media platform that you can utilize, and that is really what I wanted to share with you today, because we definitely want to get to some of those questions that you might have. So at this point, Amy, I'll go ahead and give back the screen, and look forward to the questions that we can field for all of you.
Outstanding. And holy macaroni, there was a ton of resources that are available through you and your team, Julie. Thank you so much for that great overview. I'm going to ask also Marla and Steve to come back on camera, because yes, we do have a bunch of questions from the audience. At first, we're going to concentrate on the case brief. There were several questions that came up or particular to the case brief. Marla, first one is going to be for you. A couple of folks asked, how did the case start? Like, what was the initial complaint that led you to open the investigation?
The Ombudsman's office reported several complaints to us, and then the Medicaid Fraud Control Unit. So and then from there we reached out to all the other organizations that often get the first call for elder abuse. And when we saw there was a pattern, that's when we started looking more into it.
Oh man,
if I could add to that.
Oh sure, yeah, go ahead, Steve.
We talked to the local paramedics, and they had quite a number of call outs to this particular nursing home. And the call out information was very helpful that they shared with us. So local, like first responders were very helpful in this case.
And I think both of you are just reinforcing it takes a village, as Julie just noted. It takes a whole team effort, right, to fight elder abuse. So great to hear. A couple of questions about the recording. So Steve, this might fall more in your lane. Folks are asking, did the staff in the facility know that there were video cameras installed? And can a family just install cameras if they have concerns themselves? Is that a tool that's available to family members? So Steve, I'm going to keep that to you first.
That's a good question. We wrestled with this quite a bit. We were fortunate in Jack's case because he had a private room, so there were no privacy issues. The corporation tried to raise a privacy issue, but the court said no. They had no right to privacy in a patient's room. But if there were another patient in the room, it would be different. We would not have put a camera in a room if there were more than one patient without the other patient's permission also. So there are privacy issues. Marla, you want to add anything to that?
Yes, the staff in the facility did not know that we had the recording in there. That's why it was important for the patient to get the order from court saying that they were incompetent and giving that caregiver the authority to give us consent to put the camera in there.
So here's a sensitive question that really goes to how do you balance the needs of an investigation versus caring for the victims? So Marla, I'm going to toss this to you first. The person in the webinar says, so the families of Jack and Betty allowed this poor care to take place while law enforcement is getting video evidence. How do you handle that with the family to allow the poor care to continue while you're building the case?
Communication. I mean, it really boils down to communication. So when we saw something on the video that causes the hair on your back to stand up, right? Maybe not your back, your neck, I should say. I don't have a hairy back. We would then show that video to the caregiver, right? We want to be brutally honest, right? Like, this is what we're seeing. If you want us to shut down this video right now and go in and stop what's happening, we will. So it really boiled down to full communication with the patient's family, and then also working with the attorneys, right? Making sure legally, like, you know, can we continue? Like, there's different levels, you know, of abuse and neglect that we were seeing. So, you know, it got to the point where it was too much, and then we shut it down. And so that's kind of it. It's an open, you know, discussion constantly. And if the caregiver says that's enough, then it's enough. We're not going to continue to put more evidence together at the mercy of the victim, right? So kind of what it boiled down to.
And also I would add, you have to have a plan going in. We've wrestled with this quite a bit, is if the person was in immediate danger, that would change everything. And you have to have a plan in advance of what you're going to do if that happened. Now, fortunately, in our case, that didn't happen. But if it had, we had a plan in place on how to deal with that.
I think we have time for one or maybe two more questions. And this first one, Julie, I'm going to toss to you. So Marla and Steve kind of both talked about the need for an advocate for families or loved ones to be looking out for the folks that are in nursing homes. What about the people that don't have advocates. If you have someone in a nursing home with no advocate, how are they protected from this type of abuse? Do you have any thoughts based on your experience, Julie?
Yes, they say that over half of all people in nursing homes have no one ever visiting them, ever looking in on them. And then just in our communities during COVID, we really learned how people are isolated within their own homes and are unable to get information. So that is where, in nursing homes, where the long-term care ombudsman come in. And I do not think people know that they exist. In every licensed facility is a poster somewhere that says, if you have any questions about care, quality services, here's the number to contact in our state, and then they will put you in touch with the ombudsman for that particular facility. A lot of them are very well trained volunteers, and they will come in, they will answer, they will look, they do unannounced visits anyway, but when there is an incident, they will come in and talk to the individual and gather as much information as they can, so that when during COVID, people would call us and say, I'm calling the facility over and over, nobody picks up the phone, what can I do? We would refer them to the ombudsman, they would contact the ombudsman, and the ombudsman would actually be that liaison and would call the family back and say, okay, here's what I found out and here's what's happening in the facility. So it's not perfect by any means. We need to be in touch. Marla said that village concept, we need to, there are schools, and at USC, they have a program of med schools partnering with people in long-term care facilities now, so that they get to know them. They get to know what their needs are. They get to see them as individuals with a life history. So there are innovations and programs happening, but we've got a long way to go.
Thank you for that. I'm going to have one quick question for Marla and Steve about the outcome of the case, and then I'll ask each of you for a quick takeaway. What is the most important thing that you want the audience to take with them after today? But first, Marla and Steve, a couple of different folks have asked, what happened at the end of the case? Is that facility still open? Did anybody go to jail as a result of the investigation? Can you just quickly summarize what the outcome was?
We had several trials. About half of them were convicted. These cases are very difficult to present to a jury, and I think 3 or 4 of the employees were convicted. There was also a civil suit that ensued, and the corporation settled on that for, I don't know what dollar figure, I don't recall. But one particular nurse, I believe, got 2 years in jail for her role in this.
Yeah, so often is what happens. The more egregious staff that assault and neglect, we often will charge them because we don't feel like they should have a nursing license if the egregiousness of the assault or neglect. And then 2, we're trying to make a change in the facility itself, right? There's something wrong with the facility that is allowing the staff to have these consistent complaints and these consistent issues happening in. So a lot of times they get put on like a corporate agreement and get an oversight from the Centers for Medicaid and Medicare, or oftentimes is what happens, the corporation sells to a new organization in efforts to make it better.
Wow, just how impactful to hear about what really happened in this case. It's time for a quick closing comment because we're almost out of our time together today. Marla, I'm going to ask you first. Do you have one takeaway or one key point that you'd like folks to remember from today?
Yeah, be observant, right? Be observant not only of yourself, your loved ones, and those patients and elderly that don't have an advocate. Just be aware, and if you see something and it feels off, talk to somebody about it or document it. Oftentimes, from our standpoint, we get a lot of complaints in, and obviously we can't handle everything, but our database is really good about, oh, you got one in on this facility, there's another one on this facility, and they start adding up, right? So, which then prompts additional next steps. So don't be afraid to report it, would be my takeaway.
Thank you for that. Steve, what are your thoughts? Final takeaway for our audience today.
my final thought would be, don't be afraid to make noise. Jack's wife said she learned, it took her a couple of years to learn that she had to get to the point where she didn't care if the staff didn't like her. She was going to be an advocate for her husband. And she said that took her a while to learn, that whether they liked her or not didn't matter. She was going to look at the medical records. She was going to be there. She was going to complain. She was going to go to outside sources. She was going to be a squeaky wheel. And whether they liked her or not didn't matter. They were going to mistreat her husband whether they liked her or not. So she said that took her a while to figure that out. And so I would recommend to people, don't be afraid to ask to see the medical records. Don't be afraid to take photos. Don't be afraid to look at incident reports, because they're not going to treat your loved one or the patient any better or any worse because you do those things. So I think that would be my most important point.
Thank you for that. All right, Julie, you're up next. What's your takeaway for the audience today?
Just thank you for being here. Thank you for caring about this subject matter, because elder abuse, if it hasn't already impacted you or your family in one way or another, from all the different types of elder abuse, it will. So having this knowledge, having the knowing that these resources are out there will serve you well, and you in turn will serve other people. And that's how we get ahead of this problem and makes it so that we all age with dignity and respect. So thank you so much for inviting me here today.
Beautifully said. Thank you to all three of you for sharing your time and your expertise with us. Steve, Marla, Julie, really appreciate your time and your efforts today. Thanks to all of you who dialed in to listen to what they had to share with you today. Remember that we'll have another session in the same series next Wednesday, noon Eastern. Next week, we're going to focus on a case study of healthcare fraud. So more to come on that. You'll have the link in your email that you get tomorrow with the link to the website that has all the information, including how to register for the next session. Please, everyone, stay safe, take good care, and we will look forward to the next time that we are together with you again. Bye-bye, everybody.